Okay, welcome back. Um, we've designed the conference to have the kind of singular presentations in the morning and then do panels in the afternoon right out of lunch to address some of the primary questions in the community. And I think you could see it in the presentations earlier today, but sleep and regression are two um, pain points, concerns. There's probably a bunch of different things we can associate with those two words. Fear, I think, for regression for sure. And so we invited everyone up here to help us have a conversation about sleep and regression. And so I'll just introduce everybody real quick for those of you guys that don't know them. Zoe Frazier, right here. Zoe helps lead our effort at the Cleaster Clinic and is a licensed genetic counselor. So Zoe's going to help moderate this panel. Dr. Cleaster, everyone knows. Dr. Tamar Katz, I'll say that our last trip to BCH, one of the big highlights was our meeting with Dr. Katz. And we invited her to the 2022 conference and had her out for a session. And it was something that we heard from a lot of parents afterwards how valuable the session was because I don't know if we're going to touch on it today or not, but I'll just share that we're not only talking about the kind of psychiatric impact on our kids, but also relationships with family members, spouses. And I'll just share our anecdote with Dr. Katz. When my wife and I last came to BCH, my wife and I were coming in expecting to talk about Ella. And our whole time with Dr. Katz was talking about us and how we navigate that because it is a real challenge. You heard it with Kristen's DCM report, but how we're segmenting time out for each other while also tending to someone who has increased needs is an important topic that we have to address. So I definitely wanted Dr. Katz to come back and talk a little bit more about all those areas, both our kids and us as parents and caregivers. And then Dr. Lipton is here. He is conducting the sleep study at BCH. So some of you guys might be participating in that study. He gave an incredible presentation in the fall when we did our virtual scientific conference. And again, the way that you kind of describe the circadian clock and the rhythms and how it's associated with EHMT1 is fascinating to me. Definitely sleep deprived. My daughter's upstairs taking a nap right now because she is too, I think. But obviously a very important topic to us all. So from here, I'll just turn it over to Zoe.
Is this better? Awesome. All right. Well, hello, everyone. Thank you for coming to this panel session this afternoon. This is a panel in which we'll talk about regression specifically in the context of Kleefstra syndrome. This is a really tough topic to talk about, but it's one that comes up in every single appointment we have across the whole age spectrum when we see kids in clinic. So we're really glad that everyone's here to learn more about regression, whether your child has been through a regression or not. But we hope you guys are able to take away more information and tools to help support your children and loved ones should a regression arise. Before we start, I just want to thank everyone who contributed these fantastic questions for this panel. I think it's going to be awesome. So I'm glad that we have your voices here. And yeah, well, hopefully this is a good discussion. But anyway, so just to start off, we hear about regression when it comes to neurodevelopmental conditions. Regression can come up in many different conditions. But I guess to start, Dr. Kleefstra, what are the most common features that present during a Kleefstra-specific regression, just so we're all on the same page moving forward?
Yeah, thank you, Zoe. Yeah, I think then I come back to what I showed on the slide because we are struggling with this description. If we talk about fever, if we talk about walking problems, we all have something concrete in mind, but what does it mean? Regression is a very abstract word. So we try to redefine does it mean for this syndrome, and we especially did this together during the consensus meeting for the clinical guideline I just presented this morning. So in our experience regression in the syndrome means a loss of functioning in daily life functioning, and it can be in communication, and not just for a minute or a day, but for a longer period. And it may also be expressed in behavior, really change of behavior, maybe dramatic behavior. And I think these are the most important symptoms. So a change in functioning or in behavior. And it can be accompanied by severe sleep problems. We know sleep problems are very common in the syndrome, but along with the regression, they may be that severe that an individual can't sleep for nights after each other, for example. So really dramatic changes compared to what you're used to, the functioning in your child. And yeah, I'm only a geneticist, so I'm not a psychiatrist, I'm not a neuropsychologist. I really need to rely on the other professionals to define the clinical characterization and to help and assist in treatment and management of these problems. And there, we all collaborate. That we need a multidisciplinary collaboration for such problems. And in my experience, I closely collaborate with child psychiatrists and adult psychiatrists to address this phenomenon. But I think the most experienced are the ones among you who have experienced these problems in their child, and you can as best express what does it mean, regression. Yeah.
I think we can also push this button to.
Oh, we can push it.
Yeah.
Let's just push.
Okay. So will everyone with Kleefstra syndrome have a regression?
We don't think so. But if the question is what prevalence would you expect, we just don't know. We need to still face it, though we recognize the syndrome now for a little as 20 years. The ones that undergo these kind of problems, they are as biased referred to the clinicians. And the people that does not occur, they may not come to our attention because it usually occurs later in puberty or young adulthood. And some of them might never have been diagnosed so far because there was not the possibility in the past. So we just don't know about the exact prevalence and numbers, and neither do we know if there are predictions for it, if there's more vulnerability in specific cases, or even linked to the molecular underlying defect. We just know there's a lot to learn and to gain in knowledge there. Yeah.
Yeah, we're finding the same in our clinic here in the US. We're not, a majority of our patient population are younger than the age of puberty. So it's hard to predict like who will have regression, who won't. But of the adults we follow, not everyone's had a regression. So, and it's hard to predict. But should someone go through a regression, Dr. Katz, what are some, specific treatments that are considered for people who might go through a regression?
Can everyone hear me? Thank you. So I think of regression usually sort of in three domains, and I want to be really clear. This is particular to Kleefstra syndrome. Obviously, if you have a child with different neurodevelopmental issues, the issues may be different, so we can extrapolate to some extent. And how we treat it depends on the domain that's being altered. So number one would be loss of skills. If your child has ability to read or write at a certain level and loses those skills, or blocks, puzzles, social skills, things like that, right? So loss of clear, concrete skills. Number two can be a change in cognitive functioning, where a child becomes more confused, memory is impaired, processing speed can be impaired. Social pragmatics, like understanding jokes or understanding tone of voice, understanding other people's perspective in a way that they were previously able to, that can be a second domain of functioning. And then number three would be loss of adaptive skills. So things like being able to, things that I guess are not the same as a concrete skill like reading, writing, or buttoning your shirt, but more things like sleep that can be impaired, coordination can be impaired, all of those kinds of things. And when kids have regression, I think there can be two different classes of regression. There can be temporary regressions, which are often caused by an underlying infection or inflammation or a change in environment, loss of supports if you're switching schools, if you're moving to a new home, death of a parent, loss of a pet, all different kinds of things. And you can have transient regressions. And then there's the broader sort of the real dark cloud that we all run from, which is a more just developmental regression that accumulates over time. And why does my 20-year-old not able to do the things that he or she was when they were 12? And that's not necessarily, we don't always know what the underlying cause of that is. And to some extent, there's a lot of variability within that. But where I'm going with this is that how we treat it depends, of course, on the specific symptoms that a child has. So unfortunately, we don't have a cure for regression, and there isn't anything preventative that we can do. And there's a caveat to that, which I'll circle back to. But we don't have clear medications, let me say this, that prevent regression. What we do is we just try to be very thoughtful about noticing any change from baseline, and we take it very seriously. So for example, I'm sure we'll talk about sleep in just a minute, but if we notice that sleep is altered, we try to target that right away so that we can stabilize things before they progress. So again, we can't prevent it, but as soon as we see symptoms coming, we do try to treat them. It is symptomatic management often. We're just treating the symptom. While we do that, we also do a medical workup to see if we can identify an underlying cause. So as I said, for many patients, it can be an infection, some kind of inflammation, an autoimmune condition, any kind of bacteria or virus, sometimes just life transitions. We try to figure out what the cause of it is. If there's an underlying cause that we're able to identify, obviously we treat the cause with the medical treatment for that indication. If there isn't, we end up having to treat it symptomatically. And there's a variety of medications that we would use depending on which domain the deficits are in. And sometimes patients end up on multiple medications if the deficits are in multiple domains, which often they are.
And if someone say they start a medication at the onset of a regression, will they be on that medication forever, or is there the possibility to wean off once they stabilize?
It's a great question. It's very variable. Obviously, as I said, we have these two groups of regression. So if it's a regression that we can find an underlying medical or neuropsychiatric cause for it, and we can treat the underlying cause, once the person improves, we try to wean off the medications that are treating the symptoms, because as they improve, the symptoms improve and they no longer need those medications. In terms of patients who just have unexplained regression, it really depends on the patient. Some people, we find that when we try to wean off the medication, a lot of the problematic behaviors come back. Some people, we find that over time, we actually are able to wean off the medication because regression has like phases that go with it, right? So initially a child might be more irritable or more aggressive, but as regression progresses, sometimes the child naturally just becomes calmer. And then at times we're able to wean off some of the medications, for example, that are being used to treat aggression, simply because the child themselves has changed and is in a different phase and no longer needs those medications. So it's very case by case.
And I think I'm going to jump over to sleeplessness, because that's often something that tends to be at the beginning, or we tend to see kind of at the beginning of a regression. And when we say sleeplessness, we think very significant sleeplessness. So not, they get up in the middle of the night to use the bathroom more often than they used to, but it's, significant sleeplessness. So Dr. Lipton, outside of that sleeplessness that can be seen at the beginning of a regression, is sleep typically abnormal just in general in the Kleefstra population?
So I'm Jonathan Lipton. I don't know most of you, so I wanted to just briefly introduce myself and say it's really an honor and a privilege to be here, and it's been really quite something to meet some of you and be part of this incredible community. I'm a neurologist at Boston Children's, one of Zoe and Dr. Sid's colleagues. I'm also a sleep specialist, but I spend most of my time doing research. And one of the goals of our research is a project that we're working on to try and understand the question you just asked. So the short of it is other than the work that's come from Dr. Kleefstra's group, which is very important, but still I would say limited, and please correct me, Dr. Kleefstra, if I say something wrong. We still don't fully understand the underlying phenotypes, meaning like what are the full manifestations of sleeplessness and sleep dysfunction. It seems from hearing from you and from what I understand from the clinic, it's incredibly common, and many of you are struggling with sleep with your kids. I think the short answer is I think we really need to work with you over time to carefully characterize this, which is part of what our study is trying to do, both through the use of reports from you guys, through validated mechanisms, and then all through actually measuring behavior of your children using devices like wearable devices and things like this. So I think we're very hopeful that with this type of approach, this type of like multi-disciplinary type of approach, we'll be able to sort of really unpack this in a detailed way that allows us to understand what some of the mechanisms are. I briefly could just say that having periods of true sleeplessness, like as has been described in sort of the preceding the regression phenomenon, if I call it that, is quite rare, even in developmental disorders, in which so sleep dysfunction in neurodevelopmental disorders is incredibly common. It's very, very, very common. That's why I went into this field, because this is all I would hear about in my clinic, and I had nothing for patients. But the question of an event, quote unquote, event like this, where you have a long period of sleeplessness that precedes a neurological, neuropsychiatric change, is quite unusual. And so it's something that I think is both scary. I can fully understand how that could be scary, but also provides us with a rare opportunity to try and really understand something. And so I think we need more information, so we're going to work on it.
And a question we hear a lot in clinic surrounding sleep is, are there any medications, if my child is having abnormal sleep patterns, are there medications, a variety of medications that could be considered?
Yeah, so that's a very good question, of course, and it's a general question, I think. So there's no specific therapy, as you guys all know, for Kleefstra syndrome. So as there are no specific therapies for any neurodevelopmental disorder that where a patient is going to come in with a sleep dysfunction, with very rare exceptions. There are a couple of very rare disorders where we know, for example, that the underlying circadian rhythm is inverted or disrupted. So these are also quite rare conditions where we've already understand that biology. So we do interventions that will try and reorganize or resynchronize the circadian clock, for example. But in general, most of our recommended therapies will be symptom-based. So if the problem, and so then we would end up going through so sleep behavior as in everything, but sleep especially, is all about the details. And so it's really about what your child is experiencing, what the daily habits are, what the behaviors are you're seeing. Is the problem with the onset of sleep, with the maintenance of sleep, with fragmentation of sleep, with the timing of sleep? These are all the things that we would, in a sleep clinic, would be sort of unpacking and getting into sort of the nitty-gritty. And really what we typically would happen would be you would go home with some homework, and we would sort of try and get diaries back and essentially record what behavior is, because you really can't know, typically the way most parents, and I'm not trying to say this is how you guys do, but most parents, when there's a sleep problem, it's like sleep's a disaster, and which is understandable. But we really often need to go back and like track the behavior over time and understand where the problem is. And that can indicate sort of what type of medication. So if it's sleep maintenance or insomnia, there are different sedating medications or sleep promoting medications that can be used sometimes. And it depends whether you need it at what particular time, and also of what type of strength, that we do long acting or short acting. If there's associated behaviors, obviously, there's studies being done with antipsychotics like olanzapine. There are other in that family that also we actually use in the sleep clinic because they have secondary sedating properties. Yeah, and then there's, I would say, I don't know if this is related, but there's also like the other kind of condition where we see this kind of insomnia can be like in almost like in a manic phase in people with undiagnosed bipolar disease or even with bipolar disease. And then sometimes the therapy would be like a mood stabilizer. So I would say there's no evidence for that in Kleefstra syndrome, but these are just some of the range of things. And what I'm trying to say to you is that you really need to be evaluated. It needs to be checked and discussed with an expert who can unpack these details and try and find the best series of things, whether it's a combination of behavior, light, changing feeding timing, changing other medications your child is on, as well as actually a sleep aids. So I hope that's helpful.
Yeah, it is. And going back to kind of to the olanzapine thread, Dr. Katz, what are some recommendations that you might have for the weight gain side effect that can sometimes accompany the use of these antipsychotics, especially thinking you're controlling for like a healthy diet and there's activity in their life, you know, there's regular daily activity. Is there anything else we can do to mitigate that side effect?
It's a very big challenge. It's true in both within the Kleefstra syndrome community, but also we use olanzapine for a wide variety of patient populations, and across the board, olanzapine does cause a lot of metabolic side effects and very high weight gain. Certainly, you can gain weight even with healthy diet and lifestyle, but certainly healthy diet and lifestyle do help. So, you know, as much as possible, really trying to control for diet and lifestyle, moving your body every day is really important. It's actually very neuroprotective. So there isn't data, I want to be really clear, there isn't data necessarily on the role of exercise in particular in Kleefstra syndrome. And Dr. Kleefstra, correct me if I'm wrong. But there is a lot of data coming out about the microbiome and how our diet affects neuropsychiatric symptoms and how exercise is extremely neuroprotective and very good for our brains in a wide variety of other neurodevelopmental conditions and also just in general health. So, you know, I don't want to go off on a tangent, but certainly exercise is absolutely shown to prevent dementia. It would not surprise me if to some extent it helps with, you know, all kinds of other neurological problems and symptoms. So, you know, I don't want to underestimate those things. Those are really important. That being said, it's not enough, obviously, when you're on a medication that causes a lot of metabolic side effects. And there are medications that we can use. So more and more we start patients on a medication called metformin, which is actually a medication that originally was used for type 2 diabetes and obesity, but now we also use it a little bit preventatively. Even patients who have not yet gained the weight, we tend to start metformin in parallel with olanzapine, and it tends to prevent some of that weight gain. And so that can be really helpful. And there are other medications in that family that we can use also that we often start preventatively, knowing that these medicines can cause a lot of weight gain. And it seems that starting these medications that interfere with metabolism and fat storage in certain ways do actually prevent some of the weight gain.
And when we think about Kleefstra-specific regression, we tend to think about the starting during puberty or after puberty. Dr. Kleefstra, do you know why it starts in this time frame?
Yeah, I think it is the development. Like, you know, in the general population, there's also vulnerability for certain deregulations in puberty. And young adulthood, the brain needs to, rewire, reset. I think that's also the case for the KS population. Yeah, but to point to a biological substrate or a factor, that's difficult. It's more the time period during life that's vulnerable. I think that's related.
And if someone goes through a regression and you know they recover from that regression, they go back to their baseline, you know, after interventions, could they have another regression?
I've not the answer to that. Yeah. I don't know. I really don't know. We did in our experience, we never had such a case, but the numbers are still low. So I don't know. I can't answer.
Dr. Katz, do you see any repeat, kind of like a cycle? I know a lot of your patients are younger. They tend to be on the younger age spectrum because the patient population. Yeah.
I wouldn't say that I see a cycle per se. I do see, again, I think there's a difference in terms of types of regression. So if there's a clear cause, like if a patient has an infection or has, an underlying medical condition, it is certainly possible that a person could get one of those twice in their life, right? Like we've all had strep or some kind of infection or something more than once in our lives. And so if it's if it's more of a transient regression associated with a clear underlying etiology, an underlying cause, then, it could happen to more than once, obviously, but the unexplained regression, I have not seen it in a cyclical pattern like that. But again, to Dr. Kleefstra's point, the numbers are probably too small at this point to be sure.
Yeah, going along that thread of compounding factors that might cause a regression, this is a question for maybe all three of you to answer. What other features associated with Kleefstra syndrome, what could those have impact the likelihood of someone's having a regression or, the severity of the regression? So for example, if they have a history of like sleep apnea or epilepsy in which their natural sleep cycles are, routinely interrupted, do you think that increases the risk for regression, or do we just still not know?
You're asking me.
In general, any takers.
I would say we don't know. I mean, certainly we could talk about each of the things you mentioned, but those are, I don't know about in the context of regression. I really don't know. But I don't know if we want to discuss that. Sleep apnea. These are different issues. So so sleep apnea. If obviously there are certain factors that will put you at risk for sleep apnea. Sleep apnea itself can put you. Can be. It can impact neurological function in addition to vascular function and heart function. It also just makes you behavior. It can make, especially kids, can make them. So very often, kids with sleep apnea will present with attention problems because their sleep is so fragmented. So for those of you who don't know what sleep apnea is where you have trouble breathing. The predominant form is obstructive sleep apnea, where there's an obstruction in the upper airway. It's extremely common in adults, especially adults over 40. But it's also seen quite a bit in the pediatric population. The risk factors for it are craniofacial features, obesity, thyroid dysfunction, and other things like asthma and things are also risk factors. There's some other genetic factors as well, but the good thing about sleep apnea, at least since you brought it up, is it's treatable. So obstructive sleep apnea is very treatable. There's another kind of sleep apnea called central sleep apnea, where the brain forgets to breathe. And I'm not aware of that being of patients with Kleefstra syndrome being particularly at risk for that condition. I forgot about the rest of your question. I'm sorry.
No, it's okay.
Yeah. So.
Well,
predecessors to regression. I would say we just, from my understanding, we don't know yet. That's part of what we need to learn.
Yeah, that's a big focus of why we're studying sleep right now, is because we view it as a potential precursor for these regressions. And so we think maybe if we target.
Just very briefly, I'm sorry, very briefly, I would just summarize in something you already know, but sleep has, over the past decade or so, it's become very clear that good sleep is synonymous with good health. So sleep dysfunction or poor sleep has been associated with virtually every major human disease. I think children with neurodevelopmental diseases or developmental challenges are a particular risk for the sequelae of sleep dysfunction. I'm not saying that means that we understand whether it's puts you at particular risk for regression. But I am saying, which you already know, is that sleep dysfunction contributes to all sorts of different both behavioral and physiological manifestations which are relevant to Kleefstra syndrome. It can contribute to metabolic disease. It can contribute to lowered seizure thresholds, mood dysregulation, attention problems, dysfunction with learning, participating in cares, and overall quality of life metrics. So.
And how can families who have not yet experienced a regression prepare for the possibility of a regression? Anyone, sorry. Group
So,
project.
I think it's important to remember that behavior is variable. So we all behave in certain ways and we don't do the same thing every single day. You don't eat the exact same thing every single day. Everyone in this room has had nights of good sleep and nights of bad sleep. You know, you have a night where you might wake up for an hour or two in the middle of the night and can't quite fall asleep. And that's normal. There's a range of normal behavior. So I think first and foremost, we're always balancing that tremendous fear that every sign could be the red flag of a problem, but also wanting to remember that our kids are also completely entitled to have a good day or a bad night of sleep or a bad week of sleep. So I think first, step one to prepare honestly is checking in with our own anxieties. And just being aware that behavior is variable and not every bad night of sleep is a sign of something terrible. So, you know, that's like a really important, it sounds very trite and kitschy. It's really hard to work on and implement in real life. But I think that's step one, right? Is to be checking in with our own mental health and realize, like, take a breath. Okay, that's the first thing. The second thing is, that being said, we want to not ignore problems when they arise. So it's that balancing act of not taking too many breaths. And I think if you start to notice consistent patterns, it's good just to start tracking, because sometimes when things seem like a problem, actually, when you look back at the more data we have, I think a take-home message of this panel is, like, we keep kind of saying we don't have enough data, right? And that's not only true in the community at large, but even in our own individual lives. The more data we have, the more we can actually make meaning of it. So if you have a bad night of sleep or a bad week of sleep, you don't need to start tracking. But if over the course of several weeks or a month or two or longer, you're noticing that there's, something's off, I think it's really great to just start journaling. And it doesn't have to be complicated journaling. It can be, basic step of, like, did my child get themselves dressed today or did they need help? Again, totally fine. Kids need help with things all the time. Totally normal, totally natural. Kleefstra kids are entitled to that too. But if you're noticing that skills that they used to have are becoming a little bit more difficult, coordination is a little bit off, actually just writing down and tracking, it takes 5 minutes a day, really, truly 5 minutes a day. And I think that can be a really helpful first step, because I've had families come in where they're convinced their child is having a regression. And then we actually look back over the data. I tell them to start tracking, and we look back over the data, and actually the child is doing pretty much all the same things that they've been doing all along. And there's other ways of explaining the changes that the parents are noticing. So, I think that's probably step two. Step three is, it's really great, even if your child is functioning very well now, to get connected to a child psychiatrist, pediatric neurologist, neuropsychiatry, obviously at Children's or elsewhere. So it doesn't have to be at Children's. Because that way, if you do start to notice problems, you already have a relationship with somebody and you're not just struggling, and suddenly when things are really going south, you're not, like, having to bring your child to an emergency room where you don't know anyone and they don't know you. And you have a relationship. And as clinicians, the more that we know your child's baseline, the more that we can recognize when a regression is happening, because we've seen the child when they were doing well, and that frame of comparison is really helpful for us. And I mean, I see kids as young, sometimes, I've had, like, let's say, 3-year-olds come, not because they're having any particular problem, but just because they want to establish a connection. And then I can see them every year. And then by the time they're 13 or 14, I know this child really well. And it's obviously, like, such a privilege, because your kids are so beautiful and we love them and it's just fun to see them. But also then we have that relationship and we can help monitor rather than waiting till it's going badly. I'll pass it on to our other recommendations from the other panels.
I do want to interrupt briefly and piggyback on the establishing care with, a neurologist, a psychiatrist, of any age. So if you are not able to come to Boston once a year, we know it's hard to get here, especially if you live across the country or even in close by. It's hard to travel. We totally get it. If you have an established care team at home, they can reach out to us for opinions. They can say, hey, I'm starting to notice this in my patient, and we're happy to connect with them and provide guidance from afar. Even if, we don't know your child, we're happy to connect with their care team if we're not able to connect in person. So the offer is out there. So we have a general email. It's on our website. Well, it's Kleefstra Syndrome Clinic at children's.harvard.edu. We do have some pamphlets out in the hallway, but you can email our general email, and it goes to me, Dr. Sid, and Haley in the back. So it's a short list, but we check it all the time. So yeah. Anyway, I'll hand it back to the panelists to talk about prepping for a potential regression, if there's any other thoughts. And it's okay if not.
Yeah,
Dr.
no,
Katz had
no,
a
I
great
don't
idea.
think- No, I have something to add. I think it's a good explanation. Yeah.
And besides the sleep study that we're doing right now, are there other studies that have been going on or are currently in the works about mental health in the Kleefstra population or regression?
Yeah, well, we started with studying this regression aspect a few years ago when we received a grant from the Dutch government, Ministry of Health. And there it's really challenging, but we try to, with repeated analysis, kind of make to have a study design with a systematic approach. And there we followed at least the Dutch population of 12 years and older, and we collaborate with the Boston team, who also introduced a few individuals in the study design. We were challenged by COVID. There we had a real drawback and could not visit, because in the Netherlands it's a small country, and we as researchers, or not me, but the PhD student who was involved, could visit the patients in their home environment and from the assessments. But yeah, during COVID, everything was impossible suddenly. And at some point we could recover and make remote data collection available, etc. And we are at the stage of analyzing the data, and the regressive symptoms we just discussed. So when we had a suspicion of a case entering such a regression phase, our primary drug of choice was olanzapine, because it was based on our previous experience from the study of Dr. Vermeulen, Carlijn Vermeulen. You may have connected to her as well. Where for some reason we saw that the most benefit was on that drug, though we know about the side effects, and it's also for that drug, not for every individual suitable. But that was kind of our prioritization in the treatment. And there, yeah, we did see a few individuals who really benefited from fast introduction of olanzapine in their trajectory, and they really recovered to quite some extent. For some other individuals, did not so much, in addition to relief of symptoms. So also there we are still not there, but we are currently analyzing that data, and yeah, hopefully we'll publish this soon also for the medical community. Because there in total, I forgot to mention, we followed 52 individuals over 12 years of age, and for some we are already follow in 10, or yeah, I think for some we follow already for over 10 years. So that really makes some insight in natural history.
Yeah, and some patients or some participants were also able to enroll in the Boston Children's site. So
Yeah.
we were, our site was a 2-year data collection, but even though that protocol has ended, even just coming to clinic or sending us information about your children is really helpful, because that's kind of an informal way of collecting natural history data. And we do track this information. We have a database that we use at Children's that's secure, that we use to track everyone who's come to Boston Children's, and we update it every time someone comes back. So sometimes people can only come once, and that's totally fine. take any information we can get. Honestly, you guys are such a wealth of information. But when people come back repeatedly over the lifespan, we can get these different snapshots of time. So we have research protocols that are aimed to collect longitudinal data. We're doing that in the clinic as well. And we hope to publish. With publishing comes more information for you all, for the scientific community, for drug development. It's a cycle that, a positive feedback cycle. It just keeps going.
Yeah.
So,
Mhm.
yeah, great. Well, I think, I'm not sure how much time we have left, but I feel like this could be a good time to open up for questions from the group. We want to make sure, you guys all submitted questions, but we also want to make sure if anyone has questions about what we've talked about or if anything else.